how do we use this opportunity when we have to really reimagine things to create a better system of care that doesn't have some of the things that nobody liked and were always problematic, and particularly for our patients. I have a colleague who sort of said, you know what, sometimes this is not the glossy work. And there's two things you have to remember. One, sometimes progress is left foot, right foot, left foot, right foot. You just got to do. You just got to do to move ahead. And the second is the reminder of joy is not guaranteed. You have to fight for it. And I think that that is something that maybe for me personally in my practice setting, I feel like I am looking for more and more of those nuggets of where's their joy? And the joy is in the connection. And that's the reason I do primary care. It's the stories, it's the connection, it's the knowing somebody over years of time, decades, if you're really lucky.
And now, from San Francisco and the UCSF Rosenman Institute, the Health Technology Podcast with your host, Christine Winoto.
There are certain people you meet who seem to quietly hold the healthcare system together, not with fanfare, but with deep insight, steady leadership, and a relentless focus on equity. Dr. Sunita Mutha is one of those people. As director of the Healthforce Center at UCSF and a practicing primary care physician, Sunita has spent decades thinking about how to strengthen the people who make healthcare work, from physicians and nurses to community health workers and clinic leaders. Her work is not just about research or training. It's about helping people feel seen, supported, and equipped to lead. In our conversation, Dr. Mutha shares why she was drawn to medicine, how she found her calling in workforce transformation, and why burnout is not a failure of individual resilience. It is a systems problem we have to solve together. She talks about the ripple effects of strong leadership, the power of networks, and the importance of staying grounded, especially when progress feels slow. This is a thoughtful, honest conversation about the human side of healthcare and why building a better system starts with investing in people. Here's our conversation. Welcome, Sunita. Thanks for joining today.
My pleasure, Christine. I've been looking forward to this conversation.
I know. I've been want you to be on our podcast. And I know you spoke at our symposium. And I thought more people need to hear more from you. And because you're so insightful and you have thought a lot about this work that you're doing. But I'd like to always start with your personal journey a little bit. As we all learn, there's so many different ways of people to get where they are. Let's start with what inspired you that you want to be a physician and be so passionate about this whole health workforce?
I think, you always make sense of stories after the fact. So I think the way I make sense of it now is I've always been curious about science and knowledge and discovery. I'm sure it was the fact that I grew up in a home where my father was a scientist, and these are the things that he valued. And so there was a role modeling there. But I realized as I went through college, the science was fascinating and it was really interesting, but it was frankly the people that's the most compelling for me, whether it's people's stories or understanding the context. And probably as importantly for me, it was the application, like knowledge for what's sake. What are you going to do with the knowledge? So I think somewhere after undergrad is when I realized this is just a really nice combination of rigor and deep thinking and science and learning more, but then putting it to use, putting it to improve something. And I think there's these threads in my work that are really about having knowledge, having evidence, having the information, but doing something with it, taking action. So I think medicine became that calling for those reasons. And it's been perfect for me. It's not easy, but it's been really perfect.
Well, that's good. We always want to have physicians on our back who really love the work they do. And now you are heading the UCSF Healthforce. Tell us more about what does it do, what's the mission, and why it's so important, the impact that you want to accomplish to this work.
So a couple of things. I will describe it by telling a short story about what I was drawn to when I first learned about the organization, which looked very different 32 years ago when it started. I wasn't there for the start of it, but I've seen that journey. And then what it is that we focus on now. And I would say if people don't remember anything else, probably the thing to know about Healthforce Center, that it's all about people and people in healthcare specifically. And so we are a grant-funded entity. So we contract with, or work with funders, people who are interested in understanding the workforce in healthcare, from our most professionalized workforce. So oftentimes when you say workforce in healthcare, people are like, oh, do you mean doctors and nurses? And the answer is yes, and that it's really understanding everyone who's contributing to what we now call the team in healthcare. So medical assistants, community health workers, promotoras, patient navigators, so many names, so many different roles over time. So we, and this is definitely a we, collective group of people who some of us really focus on trying to create the knowledge base, the information about who are these individuals, where do they work, how are they trained, where are they in California, how are they geographically distributed, and then nationally as well. So that's some really important work that we do, is sort of be a go-to source for information that is neutral, that has the advantage of academic rigor in methodology and a fidelity to the science. But we also look at taking that information and applying it, getting back to that theme I said earlier. And so we also do a lot of capacity building programs. We do training programs for clinicians, for administrative leaders in healthcare. We have a particular affinity and commitment to the safety net. So these might be federally qualified health centers, safety net hospitals, and all of the others in that ecosystem that are working with them. And sometimes that capacity building is by creating a network, a collaborative of people who want to come together to do good work, to solve hard problems, to learn to trust and work together and address important issues that aren't being addressed. We also do work which takes that information about the knowledge and the doing and says, well, what's the policy implication of this work? What does it mean? How does a system need to change? And so the policy can be, as we say, big P policy or small p policy. It might be what organizational policies need to change to really allow people who are part of the healthcare team to do their role fully. It might be that we actually need legislative actions and support to enable people, to give them the right set of incentives to work on a healthcare team. So it's that whole range of stuff. And I love the variety of it. I love the diversity of it. I'm absolutely committed to the mission and the partners that we get to work with.
Yeah, I do want to jump into the policy, the big P and small p, because there's a lot of things going on in healthcare. But before we go that route, is also want to ask you about. It's nice that for you to explain that it's beyond just the clinician and the nurse, but thinking about everybody who's bringing together. Without these people, care would not be delivered either. One of the things is that what are some of you have different programs, the training, the leadership part. Like, what are some of the ripple effect or the surprising outcome from that leadership training? That when you look back, it's like, wow, it's so amazing.
Oh, it's a great question. And it's, if you see the smile on my face or hear it in my voice in this case, it's because it's something I'm particularly passionate about. So, and it connects back to a question that you asked and I didn't fully answer, which is like, what's our mission? What are we about? And we really view our role at Healthforce Center at UCSF as being a catalyst to improve healthcare. And we know we don't mostly do it by delivering care, but we like to connect, and we see our role as connecting policymakers, as government, philanthropy, and healthcare leaders, and to give them the tools and the information to really drive change. So when we think about these leadership programs, we really view it in three ways. One of them is, what's the benefit to the individual who gets to participate in a program? There's great benefit, right? You come in, you're prepared, you've either had some successes and some failures, and why you haven't been able to move an organization or work or solve a problem as a leader. So that's who comes in. And we know that we have a training program that will absolutely leave them at the end of that training program better prepared. They're going to be more effective at communicating, leading teams, managing conflict, that interpersonal stuff that frankly is mostly the reason that leaders fail. They don't fail because of a lack of vision. They fail because of the difficulty in actually getting people to get behind that vision and communicating it and enacting it. But what's more important in this process isn't just their own transformation as leaders, is the organizations are stronger that they work in. And so we very much from the very beginning of our trainings think about the environment in which an individual is working. So pragmatically, that means when you come into this program, you have to have buy-in from your leader that says, yes, I know you're going there. Yes, I support this. And I do it in these pragmatic ways, like making time for you to be able to be in that program. But we, as importantly for us, is during the program, we say, you know what, you're going to not just talk about leadership or think about leadership or learn skills, you're going to apply them. And that application is all in the setting of the organization. What are you going to do at work that you can do better, bolder, bigger, more effectively? Maybe partnering with others who happen to be in the program or in this network at the same time. And so we see, I think, I believe that a big part of our role and accountability and the transformation is how organizations are stronger as the result of having better leaders. And for programs that we've been able to run for a while, sometimes we have programs that will run 5 years, 10 years. We have one now that's been over 25 years, almost 25 years. There, we can get to the really big, kind of more audacious goal we have, which is to improve care. And improving care by connecting leaders, by creating strong networks where there's trust, there's the ability to problem solve, dream even, and really think about, okay, if the problem right now in this state is around access to specialty care, how are we solving that problem? And how are we doing it not just in my organization over here, but across an ecosystem? And so I think that is where I get excited. That is where I feel like we are a catalyst. That is what, when you ask about what gives you pride or a sense of accomplishment, I look at that and I think, wow, I can see changes at the state level that are the result of individuals who trust each other, work together, have a vision, and know how to be effective in moving things forward and having progress happen. And they happen to be incredibly thoughtful, kind people, which is so needed in our environment right now, right? They're not leading with ego. They're leading with humility. They're leading with purpose. They're leading with, this is what we need to improve. And so the question becomes, how might we, not what do I get out of this? Am I getting enough visibility? But it's the how might we really solve difficult, necessary problems that leave people with healthier lives and leave communities with better resource and better access.
Yeah, I think you mentioned, like, especially in a program, you've been training people for many years, you see, because those are the long term, right? You don't see result right away, but usually those are the one that's really sticky because it's just ingrained. And it's always nice when you look back as you're doing it. Probably, it's almost like raising a kid. When you're a baby, they're so cute, all these things. But then when they all grow up and doing something, contributing to society, then you feel like, wow, that's what a journey that has to take you. And you're saying about changing the care. And I mean, now you hear a lot on the news about how challenging time it is for the healthcare worker, as well as the trust aspect of things. And everybody, it seems to be forced to do more with less. There's a lot more people who are getting older and older. That means they need more care. And as a result, it's asking a lot from our physician. There's a lot that the burned out aspect of things. Like, what are the things that you see that we need to do in order to alleviate that piece of the shortages and the burnout? Because I also learned that burnout is not so much about too much work. It's also meaningful work actually alleviate burnout, even though you spend a lot of time.
Yeah, burnout is so I'm a primary care doc, right? In addition to the things that I do, and so one really important advantage of continuing to practice is a constant reminder that, yeah, you can sit at the 30,000 foot level and be thinking policy. But frankly, when you're on the ground and you're either seeing what that policy means in practicality or how it shows up or how there's misaligned incentives and just how challenging it is. And burnout is one of those things. I think everyone who is practicing today, whether you're a nurse, a pharmacist, a physician, a dentist, has some aspect of burnout. And I think that's really telling because that gets at something that I think some parts of the field have moved on, but maybe it's less well known. Burnout is not about individual failure. It is not about individuals who just can't take it or who are too worn out and need to go take a yoga class or do self-care or whatever else which was the first set of responses to burnout was it is somehow about an individual failing to do something or to take care of something. And I think when you see it as widespread as it is now, and in these sustained ways that it's continued, there are two things that come up. One is why should anybody care, right? It's just people who are struggling, and you could say that they're very privileged anyway, and so get over it, do it. The reason we should care is there's really good evidence. There's two consequences of burnout that are really problematic. One is poor care. The quality of care delivered by people who are experiencing burnout is worse than it is for those who are not. The other is you lose workforce. And we already have such significant shortages that for people to say, I am so burned out that I cannot show up to do this work, though I love it deeply, means that the access problems get bigger. So I think what is much more visible now is that the burnout is the result of systems and structures, misaligned incentives, maybe moral injury for sure, that when you are tasked with trying to help improve somebody's health, but you don't have access or they don't have access to the resources that they need to achieve that good health, it is so demoralizing and so difficult. And frankly, it shortens lives, right? Just have people continue to not get the medications they need or access to good food or clean air or a home to live in. And so I think that the understanding that it is a systems problem, the advantage of that has been now we start to have system solutions. We're starting to really look at, well, how do you decrease some of the burden, whether it's using AI scribes to try to help diminish the typing or the multitasking in the middle of a visit. I'm, of course, focused primarily on an outpatient setting, so those are my examples I'm sharing. And there's an evidence base that has been building and a series of interventions that people are trying to say, we have created burnout. So how do we address it at a systems level to solve and try to figure out what are those points of friction that really, that we know increase it, whether it's the electronic health record, which is part of it. It's pajama time, which is that time you're at home doing the work, documenting, writing notes, whatever it is, in your downtime, in your pajamas, literally. And so I think there's much more attention to it, but our incentives are still, we struggle to align incentives as a whole, both as a country. And so when you now talk about layering onto it where we are now, which is knowing that in 2027, there'll be fewer people who are insured after all the gains that we've made in the last decade. There'll be people who are more likely to be hungry, children and adults who are not vaccinated and more likely to experience sickness. It's just, it's hard. It feels very demoralizing and now I'm talking as a primary care doctor, to think of having to have these conversations and having to sort of look and say that I don't have tools for solving those in a care setting.
What can you do under the umbrella of the health force? Because it's a big problem. And I'd like to focus on what can one do rather than we need to do this, but then there's nothing I can do about. Like, what are the areas that you guys are looking at right now in light of all what's coming?
There's two things that I would highlight, because I'm like you. I share that orientation of it's one thing to define a problem and to detail it and maybe to detail it again and the 15th time, but what are we going to do? So that action orientation theme that we talked about earlier. I think there's two solutions or two approaches, I should say, that we have. One of them is partnerships. You can't do this work alone. And so we have been really privileged that a lot of the funders that we work with, so this long-term leadership programs, those are long-term partners where we work very closely in getting alignment on the priorities of the group that's funding us, of philanthropy or government, and working closely together and say, and really focus on the how might we. Have we defined the problem clearly? Do we agree on it? Then okay, the how might we? What are the things we can test and try? What are the things we can do? The other thing is there is an incredible power, and I notice it these days particularly, where I think people feel that there's so many steps backward. There's an incredible power in gathering people. And that doesn't seem very active. Like, what does it even mean to just say, oh, we're going to either do a symposium or a collaborative or a network? But we have realized that part of what that really means is, one, there's science behind creating networks. Two, that's a necessary ingredient for solutions. And so it's not that the solutions don't always exist. It's, do they have an opportunity to grow, for ideas to be connected, for people to agree that they're going to test and try them and to come back and share? And if something is working really well in your organization and you're part of this network, can I learn that from you so I can turn around and apply it in my setting, or we can collectively think about how to scale it? So I think we look at those two strategies as being super important, of long-term partnerships, collaborations, and networks to try to accomplish these goals. And that actually, the beauty of some of that, Christina, which is great, is it doesn't matter if the issue is workforce shortages in rural California. It doesn't matter if the issue that you want to focus on, that you are saying, how might we, is about burnout or well-being. That structure works for all of those things. Mm-hmm. Or even if it's to say, because something we are very committed to at Healthforce is this issue of equity in access and quality of outcomes. So if the issue is, gosh, we don't do a very good job of doing colon cancer screening in the population that we care for, well, what are the tools that we have? What do we learn? Who else knows something about it? And then how do we turn around and use that and apply it and start making change and doing sometimes just small tests of change? But oftentimes the evidence is so strong, it's about the implementation of change, not do you have a good idea to test?
Mm-hmm. I like that, because I think you learned a lot as you execute, and then you can tweak along and you can plan all day long. You think it's getting perfect, and the moment it hit the road, it's not perfect. It's always perfect in your brain, I think. That's what I always say. The rubber meets the road, everything fly. And I was just thinking about how I read somewhere that how you make ideas stick is to make it so that it's repeatable. That means by saying repeatable is like more people knows about it. And I think that's what you're saying. Bringing people together is so important. And I know we are getting close to our time. I want to talk about, like, what are the things that the center is doing? You mentioned about the small P and the big P. Like, I'm curious about, like right now, everybody wants to like, what can we do? And you're doing it to influence to inform so that better policy. I hate to say influence, like we're doing something with this ulterior motive.
Right.
What are the things that the center is working on that you're excited about right now?
Oh, there's a lot of it. So maybe I'll go back to this theme that I raised earlier, that oftentimes the issue is not having knowledge. It is sharing and disseminating knowledge. So one of the things I'm really excited about is, as we've been doing some work around policy and trying to understand, well, who is information created for? How do we make sure that information is widely available to different groups? Is we're realizing, you know what, we have a lot of workforce knowledge that we have created over these 30 some odd years, but not everyone has access to it. So how do we take that and really think about the end goal in mind, which is either people who want to advocate for a certain change or lawmakers who want to try to look for something that has been demonstrated but could now maybe be scaled or tested in a broader way. And so we've been looking at that knowledge and say, if we know a lot about patient navigators or peer providers in helping to take care of individuals who have substance use disorders, all right, well, what do we know? How can that information then be used to help think about what the policy actions are? So we've been doing that work instead of doing our lovely academic approach, which we are all very good at, and it has a really important role, which is to create the knowledge, is we're spending a lot more time thinking about the translation of it, the dissemination of it, the communication of it, the storytelling of it. So policy then becomes not, we have a policy list of things for you that we would like you to consider, but is we want to make that knowledge visible to you, because you may know things that I don't know. You may have a context that I don't understand if you're in a position to make policy, but let me give you the best evidence to help you inform your ideas for what you want to test and do. So I'm super excited about that, because I think it makes our research and our work live and real and applicable, and moving towards this goal that we have is that we want to be this collective force. And part of what allows us to do that is to really ensure that the message gets out there, and that it is aligned. And for us, it's really a collective force for improving health, for improving equity, and taking action. So that's what I'm excited about. I've just a really deep passion for our leadership training programs. We do them for a range of groups. I feel like we have been able to demonstrate and been able to evaluate and sort of prove to ourselves and to others that work can have really meaningful, lasting impact. So it's not I came up with a great idea and we have some great research and hopefully somebody will use it. But these are real people who are skilled and trained, and they are now leading organizations. So they are like the living embodiment of what we want to, our collective ability to make lasting change. And oftentimes, these are individuals, the time we get them in the training program, they might be, sometimes they're as young as the early part of their career, and they have 30, 40 years ahead of them. And sometimes we get them sort of peak leadership time. They already have a lot of experience, but they still have a good 20 years. And they're going to enter that next 2 decades of time as a leader, much better equipped, much better connected, and with not only to lead change, but to actually stay resilient. That same issue of burnout, the burnout stuff happens to leaders. And I think the thing I'm most proud of in that setting is we learned a lot from innovation and from entrepreneurship. And I had the benefit of a colleague who really helped to shape my thinking here and really took this human-centered design and embedded it into our programs, and really looked at the lean startup work and to evidence-based entrepreneurship, and said, there are really important skill sets in here that are missing in our healthcare system. So how do we really teach those skills so that they're evergreen, they're continuously used long after the program? And I feel like that's super exciting, because then we see some changes of like what people are able to test and try in a larger scale in their organizations. But you ask them, like, so where did you get this idea from? What did you do? And they're like, it started with customer discovery. I didn't have a great idea. I knew what problems needed to be solved, but I knew enough to realize I needed to talk to people.
Mm-hmm. I think it's, I like to tell this to my kid is that you learn so much when you listen, when you ask question, and because there's so much that we don't know. You can read books, but at the same time, you're missing out certain piece. Almost like you need to have primary research and secondary research is always a good combination. I know we are running out of time here. I want to also ask, you've been in the, I hate to call it industry, but you've been in position for a while now. I'm not, we're the same age. What are the things that you see that changed for the good and changed for the one that's something that, this is something that going the wrong direction?
I'm going to start with the obvious, which is going the wrong direction, is that so many of the decisions that are being made currently feel like such a sad undoing of progress, right? I mean, California has been so fortunate to just see this immense drops in the percentage of our population that's not covered. And with that comes good health. And particularly when you think about children, perhaps starting out with healthier lives, what that means for them individually, but what it means for us in the state about our population, our workforce, that makes me incredibly sad, right? So on a human level, in clinic, what it feels like to see a loss and fear and worry about medical debt, which is the leading cause of personal debt, and to know that that's going to come back with a vengeance is really, really difficult. What gives me hope is the people. It's the people in healthcare. And it's who chooses to be in there. And they are, despite all this talk about burnout and everything else, these are incredibly creative, incredibly resilient people, right? They are not afraid of hard work. And what gives me hope is a little bit of the, for those people that are more seasoned, I might put myself in that category. It's like we've seen things before. And we have been able to see what a better future looks like, what a better vision looks like, and how we could make progress towards that. So we're not looking for solutions. We're looking for how do we recover now? How do we put some safeguards in place? And I will say our system wasn't perfect. We all know that. So how do we use this opportunity when we have to really reimagine things to create a better system of care that doesn't have some of the things that nobody liked and were always problematic, and particularly for our patients. But I think that it's, I have a colleague who sort of said, you know what, sometimes this is not the glossy work. And there's two things you have to remember. One, sometimes progress is left foot, right foot, left foot, right foot. You just got to do. You just got to do to move ahead. And the second is a reminder of joy is not guaranteed. You have to fight for it. And I think that is something that maybe for me personally in my practice setting, I feel like I am looking for more and more of those nuggets of where's their joy. And the joy is in the connection. And that's the reason I do primary care.
Yeah.
It's the stories, it's the connection, it's the knowing somebody over years of time, decades, if you're really lucky. So that's my reflection at the moment.
I know it's this is a good way to end the conversation, but as when you're speaking, it make me think about sometimes when you have experienced the good time, like you're talking about the concern about more people's not going to get coverage. And sometimes when you're in a good place, I was like, everything is fine. People don't know what it was. I'm just thinking about before the ACA got, implemented. I felt like you see that a lot on the newspaper, how people cannot afford their treatment. I mean, I see some still, but not as much as I used to. And so tell us more, like you've seen that moment, and it was just like a gut feeling when I see that? Was it, do you really feel it is also, you see that the AC has changed a bit about that part, about bankruptcy?
Yeah. No, I think you're spot on. I think that and some of these things take a long time, right, to show up and to be visible. But there are some things that were immediate. The fact that there was coverage for pre-existing conditions, that was huge.
Right.
The fact that if you had an adult child, your insurance could cover that individual up to the age of 26. I mean, those things were real burdens that people had and worried about, and that had implications for access and health. So I think you're absolutely right. I think that you don't hear about them as much because now we have taken them for granted, and that some of those things have gone away. And because you have coverage then as a foundation, and you're not so worried about just how do we decrease that rate as much, you've seen this huge growth in all of this innovation in Medi-Cal and even in other delivery systems where we're talking about things like whole person care. How do we think about, when there's tension in these discussions, but how do we think not just about the medical problem that they bring in with them, that is a part of their life that they're coping with, but how do we think about food and safety and mental health? Like, it's opened up our ability to really look at the whole person and not just their diagnostic codes and their chronic illness. And that has felt overwhelming at times, I think, for people. Like oh my God, we're going to talk about all of those social factors. And they guess we are, because that is what creates health.
Right.
And that, I think, is going to be, that was hard won. And it's going to be a hard loss. While we try to figure out how to figure out the stop gaps.
Yeah. And when that's the sad part. It's just like when you read on the same thing about measles. Nobody talked about measles. And now people start talking about measles. So this is the thing. It's almost that I guess my trying to understand has nothing to do with healthcare. Sometimes how do you make sure that you are vigilant? Not vigilant, like, what you have is something that somebody have worked on. If it's gone, you have to start all over again. But how do you remember that? Because sometimes it's like, oh, that's not a problem, because you don't feel it. It's just, that's why sometimes lived experience, you working, meeting the patients really ground you. But sometimes you are not grounded. It's hard to be grounded if you don't seek it.
Yeah. I think you're right. I think it's so easy to get used to what you have, right? And just to take it for granted. And so I think part of what I'm hearing and what you're describing is how do we keep reminding ourselves of progress or of loss of progress. And I think there's a couple of different ways, right? This is where I think that communications and news and storytelling and reporters and investigative work and research all plays a really, really important to let us not forget what progress is either needed or can be accomplished or has been accomplished and what is lost. And there's some great examples of the information that's coming out now that you're seeing as a result of things that have happened nationally, right? So you're looking at women in states who don't have access to abortion services or are otherwise constrained are more likely to have transfusions when they're miscarried. I mean, you're just seeing things about what the quality of care looks like or lack of access to care. And we have, probably even more importantly, we now have states where we know what it looks like to have work requirements. It doesn't look good.
Mm-hmm.
The research is really clear.
Yeah.
So our politics may not line up with it, but I think I think it's having people tell that story so that we don't forget that our decisions have impact. They have impact on health and what progress can look like. And then ideally, when the environment supports it, allows it, when we insist on it, using that knowledge to actually create better systems.
Yeah. I think keep up the good work, create that more evidence. And I think I almost feel that at some point the truth will come out. And it's also what you're saying, communicating. The communication skill is so important. How do you inform? Because at the end of the day, it's human who make that decision. And it's so funny, like how you inform them. It really can turn people on or off. And so I think it's great that the program that you're doing is really training the leaders in the healthcare to do just that. So with that, thank you for your time. It's great to have you on our podcast. I'm so excited to share our conversation with everybody.
Great. And thanks, Christine. You asked really thoughtful questions, and I hadn't thought about some of these things. So I really appreciate the opportunity with you. Always fun.
Thank you. Thank you for tuning into today's episode of the Health Technology Podcast. We hope you found the conversation insightful and inspiring. If you enjoyed this episode, please take a moment to subscribe, rate, and leave a review on your favorite podcast platform. Your feedback helps us continue bringing you the latest in health innovation. Stay connected with us on LinkedIn and Twitter for updates on upcoming episodes and more. Until next time, keep pushing the boundaries of what's possible in healthcare. I'm Christine Mutha, and thank you for listening.